Hello, everyone. My name is Wajiha Ali, and I lead the heme pillar at Axiom. We are a boutique think tank style consultancy working across different areas such as solid tumors, heme malignancies, as well as rare diseases. I'm joined today by our esteemed panel of Dr. Nupur Raje, Dr. Shaji Kumar, and Dr. Stein. They will be discussing myeloma, AML, and MDS updates from ASCO and EHA that happened a couple of weeks back. And with that, I will hand it over to them, and they will essentially go over the updates. We'll have interactive Q&A sessions towards the end. Do post your questions in the chat feature or send it across to us over private chat as well, and we'll ask them. And over to Dr. Kumar and Dr. Raje to take over myeloma, and then Dr. Stein will follow a couple of minutes later. Next slide, please.
All right, thanks, Wajiha. Dr. Raji and I will spend the first 15 minutes talking about some of the recent presentations from ASCO, EHA, both of which happened last month. And the 15 minutes going to be focused on some of the findings with the new quadruplet regimens, some of the updated data with immune therapies, particularly CAR-T and bispecific antibodies, both of which appear to be quite effective in treatment of multiple myeloma. Can we go to the next slide? All right, the next one. All right. So we'll start off with the important data from the Cassiopeia study. So this was a randomized phase 3 trial that looked at adding daratumumab to induction and consolidation around autologous stem cell transplant, and also looking at the role of daratumumab maintenance versus observation. We already know from the initial publication as well as the update from the ASCO that use of daratumumab quadruplet was associated with a better PFS and better overall survival. With the updated data now, we know that the daratumumab maintenance also led to a significant improvement in the progression-free survival compared to observation. However, what was quite striking was that the benefit was confined to those patients who had not seen daratumumab as part of their induction and consolidation. And there's also data with daratumumab maintenance in other settings as well. And Dr. Ajay will talk to you about the results of the LYRA study, and we can talk about both these as well. Go ahead.
So if I can have the next slide, please. As Shaji already mentioned, this is the LYRA trial. Now, the reason we're presenting this mostly is because this is probably one of the first true sort of maintenance trials using daratumumab. This was a community-based study done in the United States wherein they used an induction treatment with cytoxan, bortezomib, dexamethasone with daratumumab. Patients could or could not have gotten high-dose therapy. It was close to 100 patients. They were allowed to be newly diagnosed or relapsed. As you can see, the bulk of the patients were newly diagnosed patients. There were about 14 of them who had relapsed disease. And transplant or no transplant was at the discretion of the treating physician. I think the bottom line here was that patients were continued on daratumumab the way we think about using daratumumab on a monthly schedule, which is a little bit different from what was seen in the Cassiopeia trial, wherein daratumumab was given every 8 weeks or so. What you see out here is an improvement in progression-free survival. The addition of daratumumab clearly impacts progression-free survival in both the newly diagnosed as well as whether you had the transplant or not. And I think the other piece here was that daratumumab as maintenance was well tolerated in this patient population with really high response rates of close to 100%. I'm going to stop here, Shaji, so that we can just put DARA maintenance into perspective. And, if you look at the Cassiopeia trial, it truly was not necessarily a maintenance question. It was more of a crossover. So comments, thoughts?
Yeah, no, I think, it's really hard to interpret the maintenance data from Cassiopeia, I think one thing that is clear, is that people who had that exposure to DARA already, the benefit in continuing the DARA beyond that induction and consolidation after transplant seems to be minimal. Now, I think where the one could argue, could it have been every 4 weeks would have made a difference or not? We don't know. But I think as was shown again, we'll come to the Forte trial later on, is that maybe 2-drug maintenance is what is needed. And in that context, obviously there is the DARA-LEN versus LEN phase 3 trial that's already ongoing in SWOG. That will give us I think that will also tell us, what does DARA really bring to the maintenance space compared to what we are seeing in the Cassiopeia study.
Yeah, no, I think I completely agree. I think the LIRA study of Cytoxan, bortezomib, dexamethasone is not typically what we do, even in the United States. Certainly a good combination if there's renal insufficiency. The question of DARA maintenance will be answered by the dramatic study, which Shaji has pointed out. And there's another, Janssen-based study called the Auriga study as well, which is nearly, is close to halfway accrued, which is going to answer the question of continuous daratumumab. I think the bottom line, though, is DARA is certainly moving up front, and we are seeing unprecedented data with upfront use of daratumumab. Can we go to the next slide, please? Do you want to speak to this a little bit, Shaji, and then?
Sure. I think I think there's a lot of focus on, again, trying to improve the outcomes in the high-risk patient population. We already know with the quadruplet regimens, we can get fairly deep response and high rates of MRD negativity. And also studies have shown that if you get to be MRD negative, patients with high-risk disease do well or better than what they have done historically. So the Optimum trial was essentially an approach to intensifying the initial therapy. So we're looking at a 5-drug combination that's been given for the first 6 cycles before transplant. And essentially patients stay on the 3 most active classes of drugs, CD38 antibody, proteasome inhibitor, and IMiD, for a total of essentially 2 years of therapy, and then maintenance with DARA and LEN indefinitely. I think, we don't have the long-term data from this trial, but what is clear is that you can get very high rates of MRD negativity, which we hope will translate to a better outcome for these high-risk patients, including patients with plasma cell leukemia.
Yeah, I think they have to be commended to have included this ultra high risk group. In the interest of time, this is a phase 1 study, clearly effective combination. Let's move on to the next study. And this, obviously, the Maya study was presented at both, it was a late breaker at EHA. And part of the reason why it was a late breaker was this was the first time that overall survival data was presented. Now, we've talked a lot about quadruplets and even 5-drug combinations, as you've just heard. But the Maya study was essentially DARA, lenalidomide, dexamethasone versus lenalidomide, dexamethasone in a transplant in eligible patient population. We'd already seen a progression-free survival benefit, but this is the first time that we are seeing the updated PFS. And as you can see out here, at about 5 years, the PFS of the triplet was in excess of 52%. And most importantly, I think it's translated into an overall survival benefit of the combination of DARA, lenalidomide, dexamethasone in this patient population when compared to len dex. So triplets clearly have not just a progression-free advantage, but an overall survival advantage as well, and is probably going to be a practice-changing approach to the care of non-transplant eligible patients. Shaji, comments?
Yeah, no, I completely agree with you. I think the improvement in the overall survival is, it's always been a kind of a gold standard. And here we see that. And the good thing is the regimen is very well tolerated. And we have a median PFS that's 5 years, which is almost as good as patients getting a VRD induction, transplant, and len maintenance. So I think this definitely, while we lack the VRD versus DRD data, the data, this is pretty strong data. So maybe we'll go to the next slide. So, the cell therapy has been obviously the very exciting aspect of myeloma therapy. And Dr. Rajay published the initial results of the ida-cel CAR T earlier on. And now we have two different CAR Ts, which the one is approved and the second one which might get approved later this year. So the CARTITUDE-1, again, BCMA targeted CAR T, this is updated data. I think the most important message from the longer term follow-up is the median progression-free survival. So, we don't, or the PFS, which obviously the median is 22.8 months, but when you look at the curves, you can realize that this is probably going to be longer than that with longer follow-up. So I think one of the things we had been quite concerned about with the CAR T, despite its efficacy and the high rates of MRD negativity, has been the ability to have a sustained response. And that certainly seems to have been put at ease, at least to some extent, using the data from CARTITUDE-1. The other aspect, particularly pertinent to the cilta-cel, has been the concern for neurotoxicity, which certainly doesn't appear to be as concerning with the longer term follow-up. And clearly now, this platform is very active, and Nopur, you have published on the ida-cel data, and there was some follow-up of the KARMA trial as well at these recent meetings. So how do you, where do you think CAR T is going to be for the future?
Yeah, I think, the CARTITUDE-1 data, which was presented, unprecedented results again with a median PFS of 22.8 months, which is going to get better, as you pointed out, Shaji. And when you're seeing MRD negative disease in about 58% of people, that is something we've never seen. What we generally do in myeloma is once you see such an active drug product in the relapse refractory setting, the obvious move is to move it up front. And therefore, we'll go to the next slide, which is CARTITUDE-2. And this was presented at this year's ASCO as well. This is obviously in earlier lines of treatment. So these are patients who've had 2 to 4 lines of treatment. Again, a small subset of patients, only 20 patients. But I think one of the big concerns, as Shaji, you pointed out with the cilta-cel, was we were seeing a delayed neurotoxicity. So not the ICANS, but the delayed neurotoxicity beyond a month, way into, say, 3 months or so. And they had some movement disorders, neurocognitive disorders, which were not quite explained. So in CARTITUDE-2, obviously, when you start moving this up front, we are concerned about that. And we did use some patient strategies to prevent or to mitigate some of these. And some of those strategies include, as you treat earlier, you can be more liberal with bridging therapy. For example, treat CRS and neurotoxicity more aggressively when it occurs so that it doesn't manifest into this delayed toxicity. And by doing so, at least the early data, again, the good news is CARTITUDE-2 has sort of reaffirmed the high response rates that we saw with CARTITUDE-1. But more importantly, you do have, even though it's only 20 patients, the median follow-up of these is 5.5 months. And at 5.5 months, we are not seeing any delayed neurotoxicity, which to me was actually very reassuring in this patient population. So I do think CAR T-cell products are going to be moving earlier on in lines of treatment. We're already doing studies wherein we're, at least in the high-risk patient population, we're replacing it with transplant, and we'll have to see how the data sorts itself out.
Yeah, it's really interesting. I mean, certainly one of the most effective approaches we have seen, but obviously the concern that always comes up is, these type of therapies may be more limited to the larger centers with cell therapy facilities. So the question is, can we take some of these immune approaches, maybe more applicable to everyone? And I think one of the approaches has been the use of bispecific antibodies. Let's go to the next slide. Now, there have been a variety of different bispecifics, majority of them targeted towards BCMA, that have been presented in the past, including teclistamab, as well as many others. Now, at the recent meetings, we did see some updates of those bispecifics, but we also saw more data from the elranatamab, which was the first time we have seen the longer term follow-up with this particular product. And again, just as with the other BCMA targeted bispecific antibodies, we do see, good, excellent responses, including, some deep responses, particularly at the higher dose levels. And this is quite encouraging, and the responses, though the follow-up is relatively short, seems to be durable. The toxicity profile appears to be quite similar to what we have seen with the other bispecific antibodies. We do see CRS, mostly grade 1, grade 2, some hematological toxicity. So I think the bispecifics definitely is going to play a major role, particularly from the point of being able to combine with other standard of care agents. But the question that always comes up, especially since we have so many BCMA targeted agents, can we go after other agents using these platforms? Next slide. So Nupur, maybe you want to talk about the other ones. So.
Sure. So, this is again the majestic data, Shaji. This is teclistamab. So again, teclistamab is very similar to elranatamab, which you just presented. The good news is we have data in quite a few patients, and what you're seeing out here is high response rates once you get to the recommended phase 2 dose. And the other important thing is we started out using bispecific T-cell engagers initially intravenously, and now have transitioned to subcutaneous using, so a lot easier. And I think most of the toxicity that you mentioned, the CRS and the neurotoxicity, you do see similar to what you see with CAR T cells. Therefore, dose 1 and dose 2 tends to be given in the hospital, but after that, this is all outpatient treatment. Again, we're seeing high response rates, close to 60% overall response rates in extremely heavily pre-treated patients. And as you can see by that swimmer's plot out there, is these responses can be very long lasting, wherein patients have been getting treatment for close to a year as well. So I think more to come on bispecific T-cell engagers. This was teclistamab. We saw data on other targets, as you mentioned, Shaji. We saw the GPCR5D, talquetamab drug product, which is not out here. So I think very exciting. And in the interest of time, we'll save it for the panel discussion and move to, I think, Dr. Stern and MDS and AML.
Thank you, Dr. Raju. Over to you, Dr. Stern.
Okay, great. Thank you so much for the introduction. Let's move on to the next slide. Okay, so I think the big thing that has happened in the treatment of acute myeloid leukemia, specifically in older patients, as everyone on the call knows, is the introduction of hypomethylating agents and venetoclax for the treatment of this population. And in a randomized study of HMA venetoclax versus HMA alone, or azacitidine alone, the median overall survival in the venetoclax and azacitidine arm was improved over azacitidine alone. And the subsequent presentations have all revolved around subgroup analyses to try to get an idea if there are particular subgroups that might benefit or not benefit from venetoclax and azacitidine. This abstract that was presented looks at the subgroup of patients with AML who had a prior diagnosis of MDS or CMML, so a secondary acute myeloid leukemia, or those patients who had a therapy-related acute myeloid leukemia. So the general category of secondary acute myeloid leukemia, everyone on the call will know that there's actually a drug called CPX-351, which is a liposomal formulation of Ara-C and daunorubicin that's approved for specifically that patient population. So if you look at the response rates of Ven-Aza compared to Aza alone on the top right, you can see that the Ven-Aza group certainly has much higher response rates in the range of 60 to 70%, whether you have therapy-related AML or AML with a prior myelodysplastic syndrome. When you look at the bottom left, though, those overall survival curves are encouraging and suggest that perhaps there is a benefit for Ven-Aza in these subpopulations, although the separation of those overall survival curves, at least in the therapy-related AML group, doesn't reach statistical significance. And they don't separate quite as much as you might expect from the remission rates that we see. Nevertheless, Ven/Aza, I do think remains the standard of care now, or the new standard of care in patients who are 75 and older with newly diagnosed AML, whether they have therapy-related AML or secondary AML, and I certainly would not give these patients AZA monotherapy. Next slide. So oral azacitidine, a drug called CC486, is the first drug in acute myeloid leukemia that has been approved for maintenance therapy. So maintenance therapy was not something that we did in acute myeloid leukemia until very, very recently. And it was really based on the results of this study called the QUASAR study. The QUASAR study took patients who had AML, got into a complete remission, and for whatever reason did not get an allogeneic stem cell transplant, and randomized those patients to receive either CC486, the oral azacitidine, as maintenance therapy, or to receive placebo. And you can see on the top right that the median overall survival is improved by about 9.9 months in the group of patients who receive oral azacitidine maintenance compared to the group of patients who received placebo. If you look at the bottom left, what this abstract was trying to do was try to come up with independent predictors of survival in this study. And sort of like you might imagine, if you were MRD negative before you started maintenance therapy, the chances of surviving were longer than if you were MRD positive before starting maintenance therapy. And if you had intermediate risk cytogenetics, your chances of surviving were better than if you had poor risk cytogenetics. Age, the number of consolidation cycles you received before going on maintenance, and ECOG performance status were not statistically significant. So oral azacitidine, I think, has become the standard of care for patients who don't have an allogeneic stem cell transplant with intermediate or unfavorable risk disease. Of course, almost all of the patients we have who got intensive chemotherapy who have intermediate and unfavorable risk disease end up having a stem cell transplant. So I think although this is a positive trial in clinical practice, many of us, at least at Memorial Sloan Kettering Cancer Center, have not had the opportunity to prescribe this medication because most of our patients go on to transplant. Next slide. Okay, there's also been a question about how well does reduced intensity transplantation work for patients, older patients with newly diagnosed AML who end up having an allogeneic stem cell transplant. If you look at the bottom right here, you can see that 201 patients in this study were transplanted in CR1, and an interim analysis confirms the benefit of transplant with a 3-year survival from remission of 48% versus 37.4%. So again, there's always been a question whether in an older patient who gets intensive chemotherapy, is the best thing to do for that patient to take them to a transplant because of the risk of transplant-related mortality, or is the best thing to do just to give them chemotherapy consolidation? Certainly in this study, it suggests that transplantation, even reduced intensity transplantation for an older patient, is the right thing to do here. I think part of the reason that's the case is because transplantation, and even past when this study was done, transplantation has actually gotten safer as the years have progressed. Our ability to manage sort of the common complications, specifically graft versus host disease, has dramatically improved. Next slide. So this study gets to the question of MRD. So MRD in AML, to put it very simply, is a complete mess. And the reason it's a complete mess is because different labs use different MRD platforms. Some people use flow cytometry, some people use next generation sequencing, and there is no standardization across laboratories about how to do MRD analyses. So when you're doing a trial, if you want to do this right, what has to happen is that you have to send your samples to a central lab. What Dr. Heuser and colleagues in Germany wanted to do in this study was really ask the simple question: if we send a standardized protocol to local laboratories and we tell them, do your next generation sequencing using our standardized protocol, do you get results that are similar and as sensitive and specific across institutions? And then that was compared with the local protocol that each institution was doing. So again, looking at the bottom right-hand side here, what you can see is that when this central protocol or this proscribed protocol was used. So central means that each site used the proscribed protocol that was given, that had been developed by Dr. Heuser and colleagues. When that protocol was used, you can see that there was really very little variation across institutions, while when a local protocol was used at each particular institution, you can see that depending on the institution, there was a large amount of variation in the sensitivity and specificity of the assay. And what that gets to the point is that if we're going to be able to do MRD studies in AML, we need to be able to all be doing the MRD the same way. And the way to be able to do the MRD assay the same way is that everyone is following the same protocol. That seems like a simple thing to say, but for whatever reason, institutions are stuck doing their own thing. They don't want to deviate from what they've done for many, many years. And this lends real data to the fact that maybe some institutions or most institutions should be following a central protocol. Next slide. So this subset analysis of the Ven-Aza study, of the VIALE-A study, sort of building on the MRD that I was talking about before, asks the question of how did patients do who got Ven-Aza, who were MRD negative at some point while they were on the trial. Again, if you look at the bottom right, everything important on all these slides is on the bottom right. If you look at the bottom right, you can see in blue, that's the MRD negative patients. So the MRD negative patients have a median overall survival that is not reached, and the overall survival at 2 years is around 80%. Obviously, the MRD positive patients do worse, and in orange, do worse than the MRD negative patients. So why is this important? This is important because we're going to be starting to use Ven-Aza. We're already using Ven-Aza outside of the FDA label. We are not only restricting this drug to patients 75 and older. I think most of us are using it in patients 70 and older, and maybe even 65 and older. And if you're getting survival curves like this, again, subset analysis, not a randomized study, all the caveats, but if you're getting survival curves that look like this with MRD negative patients, I do think it raises the question of whether these patients need to have an allogeneic stem cell transplant, and whether an allogeneic stem cell transplant benefits particularly older patients with acute myeloid leukemia who get Ven-Aza and become MRD negative. And I'm hoping that that's a study, a randomized study that will end up being done at some point in the near future. Next slide. We're a little bit behind the multiple myeloma folks in that we're still only talking about doublets and triplets. We're not talking about quadruplets and quintuplets, although I can't wait till that happens. This is a study in patients with relapsed and refractory acute myeloid leukemia that is combining venetoclax with gilteritinib in patients with FLT3 mutant acute myeloid leukemia. These patients may have been exposed previously to a FLT3 inhibitor. So it's patients, again, who are relapsed and refractory with FLT3 mutations. Some of them had a FLT3 inhibitor, some of them didn't. And then they were given the combination of venetoclax and gilteritinib. On the top right, you can see that the blast clearance rate, which the authors of this abstract called the modified composite complete remission rate, but it's really just the blast clearance rate without necessarily count recovery, is 80%. Of those, about 10 to 30%, depending on what kind of CR you're looking like, have a complete remission or a complete remission with incomplete hematologic recovery. The big issue with all of our doublets and all of our triplets so far in studies with venetoclax have been the myelosuppression associated with the doublets and the triplets. This is clearly the case here as well. And we do have some work to do where I think we need to work out dose and schedule of these doublets and triplets to be sure that these patients have some level of count recovery. Because ultimately, if you clear a patient's blasts, but they don't have count recovery, they will likely die from complications of myelosuppression. So this is certainly encouraging. It's certainly encouraging the patients who have prior FLT3 inhibitors and then get ven plus gilteritinib end up responding and having blast clearance. I do think there is some work to be done when it comes to dose and schedule to be sure the myelosuppression is not prohibitive. Next slide. The VFAST study. So as I mentioned during the first slide here, there's a drug called CPX-351, a liposomal formulation of daunorubicin and cytarabine that is approved for patients with therapy-related AML and AML with a prior diagnosis of myelodysplastic syndrome. This is the first study that looks at combinations of targeted therapies with CPX-351. The only real arm of this study that is relevant because that is the most patients is arm A. And that is the question of whether you can safely combine CPX-351 with venetoclax. Like I mentioned in the last slide, when you combine venetoclax with anything, you can get very, very profound myelosuppression. We know that combining venetoclax with a different intensive chemotherapy regimen called FLAG-IDA leads to very, very profound myelosuppression and a delayed time to blood count recovery. What is reassuring in this slide is that the time to platelet count recovery and the time to absolute neutrophil count recovery in arm A, and I'm looking at the bottom left here, is what you would see with CPX-351 alone. That's a median time to recovery of about 35 days. And the early mortality is also, I think, acceptable. The 30-day mortality is 5%. The 60-day mortality is 14%. That is very similar to what you see with CPX-351 alone. And this lends sort of a basis for doing larger studies about whether, again, looking at time to survival outcomes or time to event outcomes with CPX-351 in combination with targeted agents and or venetoclax. Next slide. Enasidenib, one of my favorite drugs. So enasidenib is an IDH2 inhibitor. Enasidenib is approved for relapsed and refractory AML with an IDH2 mutation. We published a couple of years ago some experience that we had in the phase 1 setting of giving enasidenib for patients with relapsed and refractory myelodysplastic syndrome. This is a dedicated phase 2 multi-center study looking at enasidenib in patients with newly diagnosed or refractory myelodysplastic syndrome with an IDH2 mutation. You can see that the combination of azacitidine and enasidenib in these patients leads to a very high response rate of 84%. In those patients who were HMA failures and then went on to receive enasidenib, the response rate, I mean, the numbers are very small here, but the response rate is 43%. So I do think that the use of enasidenib in combination with azacitidine is something that's going to be done more often in patients with newly diagnosed MDS with an IDH2 mutation. Whether this is better in terms of time to event analyses like survival is something that's going to have to wait for a further study. Next slide. Okay, and finally into the CAR T cell therapy. So CAR T cell therapy for AML is a mess. The reason it's a mess is because the targets in AML are terrible. Why are the targets in AML terrible? The targets in AML are terrible because all the targets in AML comes from are targets that go after cell surface markers that are present on normal cells as well. You know, we learned that you can wipe out everyone's CD19 positive B cells, and that's not a problem for sustained life. It's not the same case if you wipe out someone's myeloid cells. This is a study that's been presented a number of times in various iterations of an anti-CLL1 CAR T cell therapy in pediatric patients. It's a study out of China. The efficacy in this study is really quite dramatic. I mean, if you look at these kids, I mean, these are all kids less than the age of 15. And the top right, you look at the sort of the far right-hand column, you can see that there are all these patients who are in CR and are MRD negative. I think this is very, very exciting data. You can see on the swimmer's plot at the bottom right how durable these responses are. I'm not sure this data has been borne out in other studies using the same target. The devil in all of these studies is really in the details. So it would be nice to see more details, but this is certainly encouraging, and it would be nice to build on this with greater numbers of patients. Next slide. And I think we have 2 more slides. So this slide gets at the issue I brought up previously, which is that the targets for in AML are terrible. So, you know, what you need to do then is you need to find some target that isn't expressed on normal myeloid cells. This is actually a preclinical study looking at a novel combination CAR platform targeting ADGRE2 and CLEC12A, which is actually CLL1, and relapsed and refractory AML. I'm not going to go through this preclinical study completely, but the long and short of this is that the combination CAR T-cell combinatorial platform may work better than targeting one cell surface or targeting going after one target alone. Last slide. Okay, and finally, the investment community's favorite drug, the oral IRAK4 inhibitor CA4948. You know, this is a compound that really came out of nowhere, based on some preclinical data that I believe was published in Science Translational Medicine, showing that IRAK4 long, which is an isoform of IRAK4, and may be more prevalent in patients with splicing factor myeloid malignancies, that if it is targeted, it can lead to remissions in patients with myeloid malignancies. So this is a study of an oral IRAK4 inhibitor called CA4948. There was data on like 3 patients or 4 patients, maybe 6 patients presented at ASH. We weren't entirely sure what to do with that data. Now we have updated data presented at EHA. You can see that there were a few patients on the far right-hand side that actually did achieve a complete remission with relapsed and refractory MDS and AML, getting this oral targeted therapy. One of the questions about this drug was, you know, what happens to count recovery? How myelosuppressive is it? On the bottom left-hand side, the authors are trying to show that the drug may not be particularly myelosuppressive and that the patients can get count recovery. I guess the one thing I would point out here is that, you know, if you look at at the patient who had a CRi who is MRD negative, so that's on the bottom left, the fourth, really the fourth line down, you know, these patients are sort of a little bit weird to begin with, because some of them are starting with much better counts than I would expect in a patient with a relapsed and refractory myeloid malignancy. You know, that doesn't mean that this data, you know, isn't impressive, but it is just a little unusual how good some of these patients' counts were when they started on the study. However, whenever you get, you know, any complete remissions in relapsed and refractory AML or MDS with a single targeted agent, I think that's something that's important and impressive. And certainly I look forward to seeing more data on the use of this drug, and certainly in greater numbers of patients. And with that, I think I'm done with my slides and happy to move on to the next section.
Yeah. So next, would love some insights from the panelists as a group, and in the same conversational style, on what are some of the advances that you see in your respective tumor types in the near future, in the rest of 2021 and 2022, as well as anything in the broader heme landscape. And as some of these concepts, MRD, cell therapy, allogenic cell therapy, and novel drugs like bispecifics and monoclonal antibodies emerge, where do you see the field shifting? And any specific fundamental questions also about the therapy areas that you spoke of, if those are to be answered in the coming few months or years, then probably shed some light on that.
Sure, we can get started. I think what you saw very nicely out here was, Dr. Stein presented AML, MDS. There is a focus on targeted approaches. Venetoclax was what he presented. With myeloma, we are doing more and more drug combinations. We'll start out with myeloma. I think the big question in the next couple of years is we showed you data with quads and even more 5-drug combinations. And we talked about MRD. MRD is sort of the common theme here. And the question really is, what is the role of MRD? Fortunately for myeloma, we've now at least have some consensus on getting MRD negativity at the sensitivity of 10 times -6. But, I'd love to get first Shaji's impressions on how MRD fits into clinical practice as of right now. And then Dr. Stein, I think with AML, maybe it's a little bit premature to think about using MRD if the data you just showed us is what we would be relying on, right?
Yeah, for sure. I think at least from the myeloma perspective, there's no question MRD is, it's a good prognostic tool. I mean, if you can get to be MRD negative, your outcomes are good. Particularly in the earlier lines of therapy, the relationship between the progression-free survival, overall survival, and MRD negativity is fairly strong. I think what we all struggle with right now is to, in the routine practice, what do we do with MRD results? I mean, I don't think we are at a point where we can say that if someone's MRD negative, we can either de-escalate or stop therapy, or whether we can escalate therapy if somebody continues to be MRD positive despite the standard therapeutic approaches. I mean, there are clinical trials that are asking those questions, but I think it's going to be a while before we get prospective data. So meanwhile, what do we do with that, right? So I think one area where I think most of us feel comfortable using it, might be extrapolating from some of the prognostic value, are the high-risk patients. And this has been shown, especially by the Spanish group, that if you can get a high-risk patient to be MRD negative, those are the patients with the best outcomes. In fact, their outcomes get to be pretty close to what you would anticipate from a standard risk patient. So I think there we feel like we can kind of extrapolate the data and say if you are MRD positive, despite the standard approaches, maybe intensifying therapy or changing treatment could be of value, targeting that MRD negativity. And one of the advantages we have in myeloma is we have newer therapies, particularly the immune therapies. And I think, as Nupur already pointed out, we are going to start using more of these immunotherapies upfront, but also maybe use them as an approach to driving these high-risk patients into MRD negativity. What do you think about that, Nupur, as a potential use for immunotherapies?
Yeah, I think with immunotherapy, Shaji, I think we have to be careful specifically with the MRD data because, I think one of the most important things with MRD is sustained MRD. This data was presented at this year's EHA meetings as well, looking at the Tumalin data set, and the Spanish actually presented sort of the largest data set looking at sustained MRD, where you saw MRD at year 1 on maintenance, followed by year 2. And I think the value of sustained MRD is really important. We've shown really high responses and MRD negativity with CAR T cells and bispecific T cell engagers as well. And I think it's the same problem that we see with not so much in terms of heterogeneity. I think the MRD is true, but it's just a one-off time point. So before we start using MRD in the immune strategies, I think showing sustained MRD in that patient population is going to be important. So I'd be a little bit careful there. But outside of that, I do think we already have ongoing studies where we're using MRD as a way of tailoring treatment. It's not quite ready for prime time, but the future will be, especially when you're using 4 and 5 drug combinations, when there's a lot of toxicity, both toxicity to patients as well as financial toxicity. We are going to be trying to figure out how we can start de-escalating treatment in a subset of patients.
Yeah. So Dr. Stein, maybe you want to
I was going to jump in about the MRD in AML. So as I pointed out, I think that we're not as far along when it comes to the use of MRD when it comes to just even standardization, as I showed in the presentation. It is interesting, though, that the FDA is quite interested in using MRD as a surrogate endpoint for trials for patients with acute myeloid leukemia. This is the first trial that's going to use MRD as a surrogate endpoint. Is a randomized trial of 7+3 with a SYK inhibitor called entospletinib versus 7+3 alone, where the primary endpoint of the study is achieving an MRD negative CR. Of course, those CRs, those MRD negative CRs need to be confirmed centrally because of all the issues I told you about earlier in the presentation. But it is interesting that FDA really wants to move in that direction, probably so that drugs can get approved more quickly. I do want to make 2 points about where I see the field of AML going, and I could talk about this forever, but I'm only going to talk about it for a minute and a half. One thing I think that people need to look at is menin inhibitors. There have been a couple of presentations on menin inhibitors in patients with MLL rearranged and NPM1 mutant acute myeloid leukemia. You're going to see a lot of presentations on this at ASH this year. There are 4 or 5 companies I'm aware of that have drugs in the clinic, and the early clinical data is pretty remarkable with menin inhibition in those subsets of patients with acute myeloid leukemia. The other thing I think everyone needs to think about when you're thinking about drug development in AML is that I am firmly convinced that 7+3 is going to go away within the next 3 to 4 years. And I really think the ven-aza is going to end up being the backbone that we use for all except the favorable risk patients. So anyone with intermediate or unfavorable risk disease, regardless of age, I think 3 or 4 years from now, we're going to be using ven-aza as our backbone. And that's why it becomes so much more important for us to be exploring these triplets and quadruplets now, because 3 or 4 years from now, I really think that's going to be the standard of care in our younger patients as well. And there are trials that are being developed to actually look at the comparison between 7+3 for induction versus ven-aza for induction in that younger patient population.
Yeah, I think similar to how you're going to be transitioning away from chemotherapy in AML, ETA, and I think we in the myeloma world also are going to move some of the immune approaches that we've talked about. There's some questions in the chat as well, if we can try and address maybe, Shaji. I think using CAR T cells earlier on is something we are all going to look at. We're already doing those clinical trials. But another really interesting question was, we have this off-the-shelf bispecific T cell engagers, which are showing amazing responses, and they have the ability to be able to be combined with other drugs. So where do you see the future of combinations or even sequencing of bispecifics with, say, CAR T cells?
Yeah, no, I think it's going to be a really exciting next few years trying to figure out how to position these different platforms. But I think, along those lines, I think what we are seeing is moving away from that treat until progression approach to more limited duration of more intense therapy. Not intense in the sense it's, we're using different platforms and mechanisms, right? So CAR T clearly is one approach where it's once done, you give it and you see the impact, and the impact should be, hopefully will be sustained. But the other approach is to use the multi-drug combinations, the quadruplets and the pentuplets we talked about. We can potentially use that for a limited period of time and then potentially not have to keep patients on therapy for long term. I think that's where the bispecifics really come in is, can we use that either in combination with these quadruplets, or can we use that in sequence with these? So instead of putting somebody on maintenance for 5 years, can we give them a year of immunotherapy like a bispecific as a way to get the disease burden to really low levels, so that patients can then be off treatment for several years?
I think I'll just add one more thing on the bispecifics. We're still very early on in the development of bispecifics. We're doing them weekly. I do think the future is going to look into short-term treatment, even with bispecific T-cell engagers, because of the fact that we are seeing really deep and durable responses with them. So again, a lot to be excited about. And again, I do think they can be easily combined with some of our immunomodulatory approaches, as well as some of our monoclonal antibodies as well. So there's a bunch of questions, Dr. Stein, on your concerns about, I think you highlighted them, Eitan, about myelosuppression with venetoclax and the combinations. Any comments on that?
Yeah, it's a big issue. I mean, I think that if you look at the history of drug development in AML, there are many, many trials where you get a higher blast clearance rate in the investigational arm than in the control arm. But then when you do a randomized phase 3 study, the survival is equivalent, or the survival is actually worse in the investigational arm, because blast clearance and clearance of all cells from the marrow for too long leads to patients succumbing to, serious infections. So, and all of our drugs for AML are myelosuppressive. Although menin inhibitors and IDH inhibitors aren't, most of our drugs are myelosuppressive. So most of the work that has to get done here is the work, as I mentioned in my talk, of understanding dosing and schedule in these triplets and maybe in these quadruplets. One drug that is actually not myelosuppressive is a drug that's being investigated called magrolimab. Magrolimab is an anti-CD47 monoclonal antibody. It shows a lot of preliminary efficacy in patients with myelodysplastic syndrome. There's a randomized phase 3 study that's comparing magrolimab AZA versus AZA monotherapy. And magrolimab, given that it's not myelosuppressive, is actually now going to be combined in a triplet study with azacitidine and venetoclax. And I think that drugs like magrolimab, where you don't have the myelosuppression, are going to be easier to develop than drugs like FLT3 inhibitors, where there is a substantial amount of myelosuppression.
I think you bring about a really important point. And, we've used venetoclax, and Shaji's actually led the charge with looking at the Bellini trial. And we did see significant myelotoxicity as well as infection risk. But when you really hone in on a subset of patients, we did see a benefit. So I do think it may be related to dosing. Shaji, do you want to just mention what we think about venetoclax in the context of myeloma and what the Bellini trial has taught us with respect to myelosuppression?
Yeah, Nupur, you bring up a good point. I think, again, with us, maybe we are behind some of the other heme malignancies in terms of using more targeted therapies, but certainly venetoclax gives the opportunity, at least opens up the opportunity to kind of target a specific cytogenetic group. I mean, the translocation 11-14 patients clearly benefit from that drug, even when used alone, but also in simple doublet like with dexamethasone or with some of the standard of care agents. But I think, the fact that, again, points to Dr. Stein's comment about, needing phase 3 trials to really truly dissect out the importance of a drug, right? So Bellini trial clearly demonstrated that while it benefits 11-14, maybe it doesn't quite benefit some of the other, especially the high-risk myelomas. So I think, the Bellini trial and specifically the activity with venetoclax opens up the door, I think, for biomarker-guided therapy, again, kind of highlighting, one size does not fit all in myeloma, and we need to really target the underlying biology. And I think once we get better sense of how the immunotherapies work, we might find that maybe these are specifically useful for some subgroups.
So I think one or two other open questions, Dr. Kumar and Rajay, on the myeloma side is the redefinition of multiple myeloma, smoldering myeloma, and also when we spoke about the UK study, the optimism, the definition of ultra high risk, and this is something that comes about every couple of education sessions, but if you could just let us know what the latest thinking is on these classes within smoldering as well as full-blown myeloma.
Yeah. For smoldering, again, I don't think we are going to be looking at redefining myeloma anytime soon, but I think it is a work in progress, clearly. We redefined that 6 years ago by moving some of the ultra high risk smoldering myeloma into the myeloma bucket. And as we start identifying more and more risk factors, especially the ones that afford very high risk of progression to smoldering, some of those patients will move into that multiple myeloma bucket, but probably not in the right immediate future. Now, we did come out with a new risk stratification system for smoldering myeloma, the 20-20 system, that can also be expanded to include some of the cytogenetic features. But moving into the myeloma space and the ultra high risk, it's a moving definition, and it's so that's one of the reasons why I had to be very careful how people define high risk in any given study. But one thing which is very clear is that the number of high-risk abnormalities, they're cumulative in its effect. So you have 2 high-risk abnormalities or 3 high-risk genetic abnormalities, their outcome is significantly worse. And the ultra-high risk in many of these trials have used that definition of having 2 high-risk abnormalities to define those patients. And Nupur can add to that maybe.
Yeah, no, I agree. This is going to be a moving target. I don't think we're going to redefine smoldering myeloma just as yet, but the future, absolutely. I think our goal eventually would be to get rid of the term smoldering myeloma and really, have MGUS on one end where you don't have to worry about treatment at all and myeloma, because even with the 222 classification, there's as many as 40% of patients who will not progress. And therefore, the definition of risk we all understand and appreciate is not a thorough definition, because if you decide on treating all of them, we may be over treating a significant number of patients. I think when you start looking at risk and looking at high risk features, and again, this speaks to, say, the UK study, which was presented today, the Forte study defined high risk a little bit differently. It's important to understand what the definition in that particular study is. As Shaji pointed out, this is evolving. We're now including chromosome 1 abnormalities as high risk as well. And in the future, we may be including extramedullary disease as high risk without any genetic abnormalities. And remember, there's a subset of patients who at the outset will have no genetic abnormalities, but will still progress within 1 year of diagnosis of myeloma, irrespective of whatever treatment you give. So although we think we're good at defining these features, I think biology kind of trumps everything, and we're learning along the way. So these are going to continue to evolve over time.
Thank you. And I think on that note, similar sentiments probably for the AML MDS space, wherein we identify new targets and subsets, and the disease definition is evolving. Any comments, Dr. Stein, to close that?
I think that the issue in AML is we're getting into these subsets of CR with a little bit of hematologic recovery, CR with a lot of hematologic recovery, CR with partial hematologic recovery. That is something that the FDA allowed a few years ago. And I actually think it's just confusing everybody. And it's certainly confusing community oncologists. I think it confuses many of us, and it certainly infuses people who are trying to make decisions about what the best drugs in the future are going to be for people. So I do think we need to standardize this, and we need to understand, are there differences in survival when it comes to these different subcategories of CR? And that's an effort that is not, it's not exciting, but I think it's important to do so that we have a common language that actually means something when it comes to prognosis.
Thank you. Thank you so much. And thank you so much to all the panelists. This was an absolutely on point, very crisp, but extremely insightful discussion. We value your insights, value your time and contribution, and look forward to interacting in future as well. Thank you. Have a good weekend.
Thank you
so much. Thank you.
Thank you.
Yeah. Bye.